morning, good afternoon. It's our third meeting organized especially for patients. And in this meeting, doctors, members of ITMIC will answer patient questions. This meeting is organized especially because we have a special occasion. May is a Thymic Malignancy Awareness Month. And especially for this month, this meeting for patients is organized. Before this meeting, we asked patients for questions. Thank you for all questions you submitted. And today, for patient questions, the following doctors will answer. Professor Conrad Falkson, radiation oncologist from Queen's University from Canada. Professor Dirk van Raemdonck, thoracic surgeon from University Hospitals Leuven from Belgium. Professor Arun Rajan, medical oncologist from National Cancer Institute, National Institute of Health, Bethesda, United States. Professor Edith Marom, diagnostic radiologist from the Chaim, Sheba Medical Center, Ramat, Israel. And my name is Malgorzata Szolkowska. I am pathologist from the Institute of Tuberculosis and Lung Diseases in Warsaw, Poland. We've got a lot of questions and we will do our best to answer all these questions, but we have 90 minutes for this. So we will answer as many questions as possible. First, I would like to start with a group of three similar questions about surveillance protocol. The first question was, what is the surveillance protocol for PT1A thymoma, histological type B1? Second question, similar. How often should I receive follow-up with my thoracic surgeon to monitor for any recurrence of my thymoma? This patient had thymoma type AB stage 2 in 2012, and thymus glands were surgically resected via open sternotomy. No recurrences to date. But my family doctor doesn't know how often I should be seen by the thoracic surgeon, and so on. And the third similar question submitted by a person with type AB thymoma stage 2B. What are the current long-term follow-up recommendations for thymoma patients, including those with complete surgical resections via sternotomy? Should we receive MRIs or CT scans every year or every 2 to 3 years? How often should we be followed up by the thoracic surgeon? What types of tests should be carried out? And should follow-up occur over the duration of the patient's lifetime? I wanted to propose Professor van Raemdonck to start with answering this question, but of course, all speakers are welcome if you would like to comment on it.
Well, thank you, Margaret. This is indeed an important question that patients are asking. We can say that there are no real strict guidelines, but of course we as practitioners, we can tell you as patients what we should do. And it all depends a little bit on the stage of the tumor, whether it was an early stage or a higher stage tumor, and whether we have been able to do a complete resection. So on average, we advise our patients to have a CT scan every year for the first 5 years. And thereafter, you can do a CT scan and a chest X-ray every other year for at least 10 years. And maybe after 10 years, you can still follow the patient with a chest X-ray. Now, in case you had a higher stage tumor or we were not able to do a complete resection, it is important to do a CT scan much earlier, let's say every 6 months during the first 3 years. Whenever we see something new on the CT scan, Maybe we can then also alternate with a PET scan, because a PET scan can show some tumor, better tumor activity compared to a CT scan. I think it's also good after a surgical resection to have a baseline CT scan, let's say 2-3 months after the surgery. So you can compare your first CT scan after 1 year with your baseline CT scan. Whether we should use a CT scan versus an MRI, this is also a question of discussion, but I think this is a question that can be better addressed by our radiologist, Dr. Edith Marom, and I know there are also further questions on that later on. Edith, do you want to comment on that?
Yes, I think that maybe part of the confusion is why aren't there very strict guidelines? And just like with everything else in medicine, the treatment, the follow-up is really tailored to the individual patient. So even if we only look at the histology, what type of tumor, we know by large series that if the tumor has a more of an aggressive biological behavior in general, like thymocarcinoma or type B3 thymoma, we know that there is a greater likelihood that if there is recurrence, it will occur earlier, like in the first 3, 5, 8 years. Whereas with thymoma that is very indolent, the likelihood of recurrence, of course, is much, much lower. But there have been instances when it was quiet for many years because the biology is so slow. And then suddenly 8, 9, or 10 years after, a small focus appears elsewhere. That's why your clinician may not follow exactly those guidelines. And that's why the question is whether a patient should be followed for life arises especially with those very indolent thymomas. So then you may ask, what's better? Is it a chest CT? Is it a PET CT? Is it MRI? I would like to share my screen if I can, just to show you why one is preferred over the other. So let me hold on one second. Do you see my screen?
No.
You don't. Okay, let me go out then and try it again. Wow, where is my Zoom? Okay, so I will do this screen. Okay,
Yes.
do you see it now?
Yes.
Okay, so do you see my mouse now? Is it the right screen?
We can see ITMIC follow-up and we can see the presentation now.
Okay, just one image though.
Correct, yes.
Okay, so what I wanted to show you is that the difference between CT and MRI. So with CT, images are very sharp. There's very good resolution and looking at tiny things. But on the other hand, the colors are very similar to each other. We call that the contrast resolution. So for example, in this patient who had metastatic disease to the pleura, it's this stuff, the metastasis in the bone was missed on the initial interpretation. MRI, which is this image over here, the images are very blurry, but it has great what we call contrast resolution. The colors are different. And when this patient got an MRI, we could see the metastasis. You can see how it sticks out. It stands out better. So we don't routinely use MRI because it's a very slow examination. It can take up to an hour in the machine. And sometimes it's not as available as CT, but it doesn't have any radiation. So sometimes on long-term follow-up, people like to alternate between CT and MRI, but it's not really, really necessary, okay? It's just in a matter of preference and availability. It's not that one is much better than the other. It can be whatever your clinician feels is the best fit for you, depending on the location of the tumor, the type and the questions that are asked, because it's very individualized. Now, what was said about PET CT is another thing, because this same patient, you can see, had uptake. It's the yellow of the glucose that was given. And again, on the PET-CT, it was easy to see the metastasis. But the problem with the thymic tumors is that PET-CT may be good to see things that we tend to miss only if it's an aggressive tumor. Like thymic carcinoma, for example, will have a lot of uptake. But many of the thymomas do not have very high FDG uptake. The glucose given in PET-CT is not high. So by doing a PET-CT, you gain no advantage whatsoever. Because of that, PET-CT is not a routine examination in thymic tumors in general, and is, again, only used for problem solving. So if you happen to have a question and it's an aggressive tumor, then a PET-CT may be added, but often it's not necessary. So it's individualized for each patient. Okay, I'm going to stop sharing now.
Thank you so much. Okay, does anyone want to add anything to this part, to this question? If not, let's look at next questions. This is also, let's say, a group of problem. Losing my thymus as an adult, will I have less immune defenses? Am I basically at an disadvantage compared to someone with a thymus? The first question. And thymus is a site of T-cell maturation, and T-cell play an important role in fighting over cancer in thymoma or thymic carcinoma. The T-cells have been manipulated and don't have their normal function. Does patient with thymoma or thymic carcinoma have a higher chance of other solid tumors or liquid malignancy? At the time of other malignancy, is their disease more severe in the lack of good T-cell function? Arun, would you like to comment on it?
Sure. Thank you so much, Margaret. So these are really fascinating questions and active areas of research. But there are some answers based on studies that have been performed and data that has been published in the past. There have been series that have looked at the effect of thymectomy in individuals who might have received it either as treatment for myasthenia gravis or where it might have been removed in individuals as children when they had cardiac surgery, for example, in the setting of congenital heart disease. And in those situations, when those children grew up and when they were adults, folks have looked at the immunological immune system, the various types of immune cells, immunoglobulins and so forth, to see if there are any persistent deficits which could have clinical manifestations. So based on the data that's available, the answer is that yes, removal of the thymus can cause or does cause some sort of immunological changes, especially related to T cells. These are sometimes changes in numbers, but these are relatively mild, a decrease in number of T cells and changes in different subsets of T cells, because there are several different categories of T cells, and some may be decreased, others may be slightly increased. And what are known as memory T cells, which develop over time, those numbers remain normal. So that's what we know about the effect of thymectomy on T cells. As far as other components of the immune system go, such as B cells, which is pretty important, those numbers are actually not affected. In these studies that have been published, those numbers remain normal. And when we talk about immunoglobulins, which obviously also have an immune function, certain categories of immunoglobulins can actually be higher than they would normally be, even in the setting of a thymectomy. And mind you, these are studies done in individuals who had thymectomies several years and in some cases decades before these blood samples were analyzed. There's also a recognition that certain types of what we call autoantibodies, which are typically related to certain autoimmune diseases, their numbers can be higher, or titers as we call them can be higher, but it does not translate generally into an increased risk of autoimmune disease. So to sum it all up, based on what we know, there are changes in quantitative and qualitatively in parts of the immune system, but it does not have major clinical manifestations in the form of increased risk of autoimmunity or increased risk of infections and so forth generally. As far as the effect of thymectomy or even the presence of a thymic tumor on the risk of other cancers, the cancer development in general is thought to be due to defects in what we call immunological surveillance. So there are various environmental or genomic insults. These cause nascent tumors to develop, which obviously cannot be detected very, very early in the course. And the immune system clears these off. But if that immunological surveillance is altered, it could cause an increased risk of cancer development. So that is true across the board, not just for thymic tumors. There have been some population studies that have been published. We had published one several years ago from the NIH, and there have been others from other parts of the world as well, which do show that just based on population statistics, there are certain cancers where the risk could be a bit higher in the setting of a patient with a diagnosed thymic epithelial tumor. And it's, again, not a uniform increase in risk. There are certain cancer types where you see perhaps an increase in risk, but there is no definitive evidence, to my knowledge, to suggest that it is the presence of the thymoma that caused the second cancer to develop or arise. There could be shared genomic characteristics or other factors, environmental factors, viral factors, etc., that we just do not know about. In terms of whether these malignancies are, more aggressive, again, based on what we have observed, the answer is no. They seem to follow a parallel trajectory, and they may not be more or less aggressive than they otherwise would be.
Thank you, Arun. So much. Yes?
Margaret, I might just want to add there that a lot of the work that was done was originally done on mice, and mice that are born without a thymus do have a defective immune system. But even children, human children that are born without a thymus, do not have a completely defective immune system the way it occurs in other animals. So it's not quite as simple as it just being the thymus in humans.
Thank you. Okay, let's look at next question. Is recurrence of thymoma more likely if you only have clear margins of less than 1 millimeter, or are there other factors? I think it's a multidisciplinary question. Who would like to start? So margin is very small. Is the recurrence of thymoma more probable in such case?
Well, thank you, Margaret. Maybe I can start off as a surgeon. Of course, we like to have a big margin as large as possible, but sometimes it's not always technically possible. For instance, if you have a vital organ just next to the tumor, you cannot cut into that vital organ, let's say the heart or a big large vessel. Sometimes we have indeed only a small margin, let's say just 1 millimeter, but if the resection is complete on the histology, it means that it is complete. And even with a small margin, it doesn't mean that the tumor will come back. Now, from time to time, there is no real other margin. And what I want to say is that it's well possible that beyond the tumor, you have a cavity like the heart cavity or the lung cavity. We call it the pericardial reflection or the pleural reflection. And then the tumor is not adjacent to any other structure. And if you can then take off the tumor completely, even with a margin of 1 millimeter, you will have still a complete resection.
Thank you. Arun, Conrad, would you like to add something from your side?
I can perhaps mention that it does also depend on the histology. If it's a thymic carcinoma, a close margin is of more concern than a stage 1 T1A type A thymoma. So the behavior of the tumor also needs to be taken into account, not as well as the location.
Mm-hmm.
Completely agree.
Okay, thank you. Next question. I have met with several oncologists, but no one can tell me the size of my tumors. What questions should I be asking in order to obtain this information? Whenever the doctors show me PET scan images, they don't seem to be able to explain what we are looking at. Edith, would you like to add something? We don't hear you. We can't hear you. Please unmute.
Sorry. Yes. Okay. Sure. So let me share my screen one more time with that same image. Okay. And we'll do the same thing as I did before. And I will put this over here. So let me explain to you what the PET is, okay? So when we say, why is this not moving? Okay. When we say a PET scan, let's try to understand what that actually is. A PET scan is when one injects marked glucose, sugar, which is not specific. It goes to anything that's active. It could be tumor, it could be inflammation. But in the setting when there's tumor and someone's not suffering from infection, it will mainly go to the tumor. But the images that are produced by this are extremely blurry. So if we look at this image over here, this is a combined machine, a PET-CT. But a dedicated PET scan, the only image that will come out is this one over here. Do you see my mouse? Yes. And you can see that it's so blurry that if I had to measure the size of something, one point to the other, it would be impossible. And also the way it's displayed, I can just make it, change it to be like a big light bulb or small. It has no meaning. So then I think so you cannot measure size by the PET scan. But if you're talking about a combined study, which most of the PET scanning today is done as a PET-CT and not just a PET, what the machine does at the same time, it acquires a PET scan and a CT scan and combines them so we can see on the fused image, which is the image over here, the image. Again, you cannot measure the size by the uptake. You can see this little dot of yellow over here. This is a metastasis in the rib. You cannot measure it, the size. So the measurements for size are actually performed on CT, not on the PET. So when one gets a PET scan only, you cannot follow with size. Now you can measure how much uptake, how much glucose went there, but in most places we do not like to follow from one study to the other and see if the glucose is a little more or a little less, because it's very inexact. There are many technical factors that change from one imaging study to the next that make the results not as reliable. So we use it a little bit for guidance, but not as a clear number. We like to look at size. So the main question is, can my physician measure my tumors on the CT scan? It may be the CT acquired during a PET-CT scan, but it's on the CT scan. So the answer is, sometimes it's easy and sometimes it's not. So remember the study that I showed before, this one. How does one measure pleural metastasis as big as that wraps around the entire chest like that? It's very difficult because it's round. You cannot put straight borders and do it well. So when it's easy, when there's one nodule and you just measure a diameter and the margins are clear, it's easy to measure, and we often do that. But sometimes when the tumor is infiltrative or when it goes around the chest and doesn't fall into one diameter, the measurements become more challenging. So the question that you asked, that the clinician cannot show you the sizes, again, are individualized. I don't know the case. Sometimes it's easy to measure, but sometimes it's impossible to do it reliably.
Thank you.
I will unshare.
Okay. Thank you so much. Next question. what is the value of adding anti-angiogenesis drugs to standard triple chemotherapy? Arun.
Thank you. So the concept of adding anti-angiogenic drugs to chemo has been around for quite some time, and has been used in, against various advanced cancers like lung cancer and colon cancer and so forth. The effect, the benefit of this additional anti-angiogenic approach has been quite variable. As far as thymic tumors are concerned, by triple chemotherapy, I'm assuming we're talking about frontline regimens such as platinum, adriamycin, cyclophosphamide. It is not considered standard to add anti-angiogenic drugs to frontline chemotherapy because the clinical benefits are uncertain and the risks are real of bleeding and such. Having said that, there is an ongoing study called the Leuven trial, which I believe is a randomized trial with platinum chemotherapy, carboplatin, paclitaxel, with or without the anti-angiogenic drug ramucirumab. And that trial, it's a prospective study. I believe it's accruing patients as we speak. And as far as I know, no results have been published. But when data comes out from that trial, it would be informative as to what that approach means for thymic cancers specifically. There is also some retrospective data that has been published from China from a few years ago that evaluated bevacizumab, which is an anti-angiogenic drug, which was initially evaluated in various cancers, along with carboplatin and paclitaxel. That was for relapsed thymoma or thymic carcinoma. And what that study, that small study with all its caveats being retrospective, what it showed was that first, thymic carcinomas appear to be more sensitive to this approach. And that stands to reason because as far as the effect of angiogenesis is concerned, it's known to be more for thymic carcinoma than thymoma. The response rates numerically were a little higher than what we see with carboplatin and Taxol, but you have to take that with a pinch of salt. It was a small study and it was retrospective. And in terms of durability, how long the effect lasted and when a relapse occurred, in fact, it was not very impressive compared to some of the standard drugs that we used in the second line setting and beyond, including drugs with anti-angiogenic properties such as sunitinib or lenvatinib. So I think in terms of a prospective trial and data, those are lacking, but there is an ongoing study that will inform this question. As far as single, I know this is not exactly the question, but if you look at just drugs with anti-angiogenic properties without combinations with chemo, there is an established role. So as some of you may know, lenvatinib and sunitinib are used in the treatment of relapsed thymic cancers. So there's certainly a role there. But one thing I would also point out is whether all of this is due to the anti-angiogenic effect of these drugs or other effects is something that needs to be figured out. And by other effects, I mean immunomodulatory effects, because we do know, for example, a drug like sunitinib that we had evaluated a few years ago, it does have properties that are immune modulatory and that work against the tumor. So some of these issues need to be clarified, but the short answer is the relevant study that's ongoing will inform this question about the value of adding these drugs to standard frontline chemotherapy.
Thank you. And next question. After developing intermittent diplopia, I was found to have a thymoma as per a multidisciplinary team. I started steroids, and on thymectomy pre-op scan, it shrunk and no longer looked like a thymoma, but thymic hyperplasia. Hence, the thymectomy was cancelled and now under surveillance. What is the role of steroids in managing thymomas? It seems to have cleared my thymoma. If steroids can shrink thymomas, is there pre-op benefit for surgical resection? First, my short comment as a pathologist for this the situation described here. If I understand correctly, this thymoma was not confirmed microscopically. It was just the suspicion of thymoma based on perhaps radiological findings, maybe also perhaps symptoms, because I guess that myasthenia gravis was diagnosed or suspected. But thymoma was not confirmed. So we can't regard this case as thymoma disappeared and now it is a thymic hyperplasia. This is first, so we can't regard this influence of steroids, we can't regard it as a method for disappearing of thymoma. Arun, perhaps you would like to tell more.
Absolutely. So thank you, Margaret, for those insights. So as a medical oncologist, first of all, I can't comment specifically about this case, but I would say in general, can steroids cause shrinkage of certain thymic tumors? The answer is yes, it can. Generally, it is more so in the thymic tumors that are more enriched in lymphocytes. So, for example, something like a B1 or a B2 thymoma, the effect could be more pronounced than it is for a pure carcinoma, let's say thymic carcinoma, or maybe certain B3 thymomas. Can it have an effect as preoperative treatment in shrinking these tumors? Now, that is a question that really depends on a lot of factors, patient-related factors, the tumor itself, its location, what the challenges might be for a surgeon who would be operating on it, with the ultimate goal of getting a complete resection. So those issues have to be really discussed in a multidisciplinary forum. But are there instances where the additional shrinkage that might occur for a lymphocyte-rich thymoma with a addition of steroids, might that have a role in certain very, properly selected cases? The answer is yes, it could. We have, on instance, when some, patients have a large burden of disease to begin with, and the histology that is thought to be maybe sensitive to steroids, we have used high dose, what are called pulse steroids, either prednisone or there's literature for methylprednisolone as well, along with the standard chemotherapy. So it's not steroids alone. It's just as a supplement to chemo to maybe increase the depth of response, the degree of shrinkage. So it makes it easy for a surgeon to get a complete resection. So that's my take on from a medical oncology side. But I would say for advanced disease, the role is somewhat limited, although yes, tumors can shrink with this, but it's not a tenable solution because, steroids can have tremendous negative effects. They can have, they are immunosuppressive. They can increase the risk of, infections, including atypical infections that could be life-threatening. And these are real, infections like pneumocystis pneumonia and so forth. It can have other consequences such as osteoporosis, peptic ulcer, disease, and so forth can occur if there's long-term use of steroids. So that by itself is not a be-all and end-all treatment, in my opinion. There are some, certain situations where they may be used. So for example, some of you may have heard of the drug octreotide, which is useful in certain circumstances for specific type of thymomas. And there is evidence to show that if you add steroids for a certain amount of time, it increases response rates. But those are very specific situations, and I would not treat steroids as a standalone treatment for thymic tumors, especially in the long run, would be my take on it. Thank you.
Mm-hmm. Thank you. But do you use steroids in cases with autoimmune diseases associated with thymomas, or even if there is no, let's say, myasthenia gravis or other diseases, just to reduce the tumor as an additional treatment?
Certainly, yeah. And I'm sorry, I didn't focus on that aspect. So as far as autoimmune diseases are concerned, absolutely, there is a role. But there too, one has to be careful because there is increasing recognition that there are certain autoimmune diseases where other immunosuppressive drugs are more effective than steroids. But generally the concept is for most autoimmune diseases, steroids do have a role. But again, there are lots of caveats. So that's just a general statement. As far as the comment that you made, Margaret, in terms of the use of this of steroids in the setting of as a supplement to chemo in the preoperative setting, especially, the instances that I quoted and the trials that have been done are independent of autoimmune disease. So there it is basically just steroids used to increase the response rate of chemotherapy in very, very selected cases. In most cases, it may not be needed. But that's independent of whether there's autoimmune disease. So that's more as a thymoma-directed treatment rather than for management of autoimmune disease.
I see. Thank you. Dirk, you would like to?
Yes, one more comment. If I read the history of this patient carefully, it's well likely that this was not a thymoma from the beginning, that this was just thymic hyperplasia with some nodular thickening of the thymus. And so if no biopsy was done, you can never say that it was a thymoma. And we will talk on biopsies later. What you can do in this case is do a PET scan and look at the intensity of the yellowness on the PET scan. And that can make somewhat a difference between thymic hyperplasia and thymoma. I'm sure that Edith can say more about that also.
Yes, Edith, please.
Yes, actually, the study of choice to differentiate hyperplasia, which sometimes can mimic a thymoma, is MRI. There is a special way to do the MRI image where it differentiates between thymic hyperplasia and thymoma. Again, the PET-CT is great if there's great uptake, like in thymic carcinoma, but the problem is that with hyperplasia, sometimes there's uptake as well. So that's a problem. Not every uptake actually means tumor, because as we said before, not everything that eats up glucose is actually tumor. It could be inflammatory. But also we have thymomas that don't have increased uptake. And that's why we don't like to use it, and we prefer the MRI if available.
Thank you. And next question. I have stage 4 thymic carcinoma with metastasis to the liver. There are too many tumors in my liver to be operable. Before my liver functions degrade considerably, what are the more aggressive procedures or treatments used to reduce or eliminate these liver tumors? Arun, maybe you would like to comment on.
Sure. So in a situation where the tumor is deemed inoperable and there are liver metastases, I think the bottom line is to figure out and identify the most effective systemic therapy because most systemic therapies are effective in the liver. You know, whether it's frontline chemotherapy or if the tumor comes back, additional chemotherapy or drugs such as lenvatinib and so forth, these can have, you know, quite some activity in the liver. So I think it's important to recognize what might be effective and use it. I think the question alludes to the fact, perhaps if I understand correctly, that, you know, the question as to whether there are liver-directed therapies, and the answer is yes. Now, this is a highly technical matter, and again, it needs multidisciplinary input, especially from interventional radiologists and specialists who do these sort of treatments. But yes, there are what are called liver-directed therapies, and these are you know, used in the setting of liver involvement, regardless of the type of primary cancer. So, for example, the embolization, transarterial embolization, or you can use chemotherapy with it to deliver it focally, you know, to the liver. So that's called transarterial chemoembolization, or TACE. And then there are other forms of local therapies, such as you know, thermal ablation and you know, even radioembolization. And perhaps Dr. Falkson can speak to the use of yttrium-90, which I believe is used in the form of microspheres in certain situations like this. But those are very highly technical. It is not, you know, a situation where it's a given that it can be used. It depends on the extent of liver involvement, the size of the liver lesions, the location of the liver lesions, and as importantly, if not most importantly, liver function. So some folks may be candidates, especially if they have liver predominant disease. I tend to sort of think about these things. But if there is, you know, metastatic disease elsewhere and the liver is one site of metastatic involvement, I think the key really is to use effective systemic therapy, in my opinion. Conrad, would you like to add to this?
I can mention that the isotopes have been looked at and have been used, and they're still very much experimental at this stage. A lot of it depends on the volume of disease within the liver and how selective these isotopes can be at targeting the areas, leaving enough normal liver tissue for recovery. The liver is remarkable in its ability to recover. I think that more what plays a more prominent role these days is targeted therapy in terms of surgical resection and targeted radiotherapy, which we can do. But again, it's all dependent on the volume of disease within the liver. And is it reasonable to target the individual lesions? Because quite often what we see is only a fraction of what is actually there in the liver. And so the first line would be systemic therapy.
I see. Thank you.
And if I may just add to that, and perhaps Dr. Marom can comment on this. So that last point that Dr. Falkson made is incredibly important, I think, because as a medical oncologist, I sometimes, we get CAT scans for routine follow-up, and you see a couple of liver lesions, and you ask your surgical colleagues and radiation oncology colleagues whether you can do targeted therapy to resect maybe those 2 lesions or, offer some local therapy. But when you follow that up with an MRI of the liver, sometimes you pick up things that may not even be visible on the CAT scan. So it's really important to make sure you know what you're dealing with and how much disease is in the liver before you embark on these local therapies or develop a plan.
Thank you. Edith, would you like to add something?
No, that is true. And what Dr. Rajan said has to do again with what I told you before, that although the images are slightly more blurry on MRI, the differences in the soft tissue is greater. So additional liver metastases are highlighted and easier to see. But again, it's not used routinely on every follow-up because the exam is long, not always as available. So we use it selectively for specific questions, such as what was suggested before local treatment, when we want to make sure.
Thank you. And next question, what do you actually know about thymic carcinoma, and how much CT have you done regarding it? I must admit we didn't know exactly what patient mean in this case, what is CT. Maybe it is a typo here. Maybe it was a question about CRT, controlled randomized trials. We are not sure. It's actually to answer these questions, perhaps we should organize a separate webinar concentrating only on thymic carcinoma. It's a huge topic. However, I don't know, maybe Arun, you would like at least in few words answer this question.
Sure. So the shortest possible answer is thymic carcinomas, we know a lot more today than we did a few years ago, and that knowledge base is constantly expanding. We obviously know that thymic carcinomas are, distinct from thymomas, even B3 thymomas. There are different genomic characteristics. There are different immunological features, which we are constantly learning more about. There are certain novel targets when you think about identifying targets against which you develop treatments. There are certain targets which are more applicable to thymic carcinomas than they are to thymomas. So, for example, one example is this protein called mesothelin that we had discussed a few years ago. And then, in terms of clinical trials and figuring out exactly what the benefits and the risks are in patients with thymic carcinoma to be specific. Nowadays, when we do studies, there are specific cohorts within clinical trials for thymic carcinoma, or for certain drugs that are effective against this histology. Those, clinical trials may be open for patients with thymic carcinomas alone. And this is there is a distinction to be made here, because the historical trials which brought into focus the very first chemotherapies, they were done across the board in a patient with thymic tumors. It was not so much histology focused. So that is a change, and that's the change for the better. If we are talking about randomized control trials for thymic carcinoma specifically, as I mentioned, there is an attempt. There is actually, we routinely now assess thymic carcinomas independent of thymomas, but there are not too many randomized control trials because these tumors are very rare and it's difficult to conduct such studies. That's the brief summary of where we are with thymic carcinomas. But as Margaret mentioned, there's a lot of data coming out to inform the biology and the management of these tumors, and that's a topic for another day, perhaps.
Thank you. And the next question. I had an operation last May to remove a thymoma. When the pathology came back, I was told it was a thymic cyst and I wouldn't be having any follow-up scans and was discharged. Is a thymic cyst different from a thymoma? Should I be having scans to check all is still okay? It scars me that nothing is being done. So maybe I can start to comment on this shortly from pathology point of view. Yes, thymic cyst, it is something completely different than thymoma because thymoma is a malignant neoplasm. Thymic cyst, if we are thinking from histological point of view, is a benign lesion. And very often it is even developmental abnormality. So from histological point of view, there are completely different entities. However, I noticed from our practice that sometimes thymic cysts are perhaps difficult for radiologists to diagnose, and sometimes thymoma is suspected, but under microscope we can see only thymic cyst. There is such a cyst in thymus named multilocular thymic cyst. It is not so, I think, not so easy to diagnose radiologically. I'm sure that Professor Marom can say more about it. And I saw such cases that thymoma was suspected, but under microscope there was only thymic cyst, and vice versa, that, for instance, thymic cyst was suspected, under microscope was thymoma, but it was usually it was an issue of this very specific multilocular thymic cyst. Edith, would you like to comment?
Yes. Please. So indeed, true, Margaret. So sometimes there's a cyst which is just like a balloon. But the problem is that the fluid in the cyst, sometimes it's clear like water and you could make the diagnosis with a CT, but it can be tricky when it bled a little bit and it's denser, or when there's some protein in it. And then when you look at CT, it looks like soft tissue and you say, oh, this is a thymoma, let's get it out. So we now are more aware of it. And sometimes when we think maybe, we will do an MRI. Why? As I said before, MRI may look more blurry, but the colors between soft tissues are better. And it's easier to appreciate that something is fluid and that there's no soft tissue within it with an MRI. So sometimes, if we suspect it on time, we will do an MRI, we'll prove that it's a cyst, and then the patients do not get surgery unless they want to, because they feel uncomfortable. So, and of course, the multilocular cyst means that there are many compartments, so there are walls, and they behave when you do the different imaging studies more like soft tissue. They're alive, they take up contrast, and it sometimes becomes impossible to distinguish that from a thymoma. So we still do see sometimes surgery for cysts, but much less than before, because when we equivocate, we ask for an MRI, and sometimes some of them we're able to say, okay, you know what? This is not a thymoma, this is a cyst.
Thank you. And Professor van Raemdonck, please comment from surgical point of view.
Yes, in addition to what Dr. Marom has said, I want to address two more aspects on this question. First, sometimes it happens that the thymoma becomes somewhat bigger and that the inside of the tumor dies. So that is an infarction of the tumor. And usually these patients present with acute chest pain. And then you can have an image on the CT or MRI of what we call a cystic thymoma. It's just a thymoma with the inside necrotic tissue. So we have to differentiate that from a thymic cyst. Number two, the question on the follow-up, I can understand that the patient is a bit worried. What I usually do in my practice, I tell the patient, listen, this was a thymic cyst. It was not a malignancy. You don't have to worry. But in order to make sure that nothing is left behind, we will do one more CT scan, let's say a couple of months after the resection, after the inflammation has come down, so that we can show you that everything has been removed.
Excellent. Thank you. Thank you so much. And next questions, similar questions regarding biopsy of mediastinal tumors. Are there any studies or statistics on the rate of recurrence in thymoma patients that have had biopsies prior to thymectomy versus those that have not had biopsies? And similar questions. There has been a lot of talk about not having a biopsy due to chance of spreading. It makes sense not only for thymoma, but also for every tumor. Why is different in thymomas? And it is my understanding that the statement works when the mass is respectable and encapsulated. What are the guidelines for having a biopsy on a recurrence or on a mass different from the one on the thymus gland? Dirk, would you like to answer, please?
Yeah, there are also different aspects to address. First of all, we all agree that when a tumor looks well circumferential encapsulated, we do not like to take a biopsy at all. If we all agree this looks like a thymoma, don't take a biopsy, because then you risk that the tumor cells are spreading, especially because these tumors are close to what we call the pleural cavity. And if you open the pleural cavity, these tumor cells can then start to spread in the pleural cavity and come back as a recurrence 2-3 years later. So if we all agree this is a well-encapsulated thymoma, we will not take a biopsy. And this may be different to another cancer that is where the spread will not be so aggressive as with a thymoma. Now, whether a thymoma biopsy will result in recurrence, yes or no, there are no randomized studies or comparative studies to answer the question on the left side. So in conclusion, I can say we don't like to take biopsies of thymomas unless we are in doubt that this may be another tumor. If it's a real big tumor and it may be a lymphoma, and in order to decide on which treatment the patient will need, then we will take a biopsy.
Thank you. Does anyone comment on this question as well?
Yes. I would like to say something. We do not have data that there is an increased likelihood of spread along the needle track when doing a biopsy on a thymoma compared to other tumors. There is a notorious tumor that does it, and that's mesothelioma. That's a different story. But the reason sometimes why we do not choose to do a biopsy and we say, you know what, this needs to come out, also is due to what happens, and this can occur with any biopsy. When you have something that is very highly suspicious for a malignancy, you do a biopsy, and you know you're not biopsying the entire tumor. You're just taking a tiny, tiny, tiny piece of that tumor for the biopsy, and it comes out inconclusive, where not enough tumor cells came out, and you cannot decide if something is benign, malignant, or maybe you biopsied in a necrotic area, which was mentioned before. This can happen, and then you just get fluid and it's no real tumor cells. What do you do in this case? So when we encounter a tumor, a mass, and we say, you know what, for sure this is tumor, so it needs to come out, and I don't care right now if it's this type of thymoma or that type of thymoma, because the treatment is that it needs to come out and it's small enough that I don't need to give therapy before the surgery. And that's why sometimes and often we say this looks just like a thymoma, that even if I get a negative biopsy, I will still be suspicious and this should not be left inside. And then the answer is, so why bother with a biopsy? It needs to come out, and we just go and do it.
I absolutely agree. From pathological point of view, it is a small biopsy. It is much more challenging for pathologists to establish the diagnosis correctly than to have the resected tumor. So if the tumor should be resected, regardless the diagnosis from the biopsy, why to biopsy this? Conrad, you wanted to say something.
Yes, with regards to biopsy and seeding along the tract in general, this has always been a concern, and there's a very big difference between a biopsy being taken with a needle and contamination at surgery because the whole tumor is disrupted. But the reality is that even in mesothelioma, which is a tumor that has a higher risk for spreading along tumor body planes, there is not enough risk to justify offering radiation to these patients to try and prevent it. The risk is really very, very small in the tumors that are most likely to spread, and thymoma is not one of those.
Thank you. Arun, please.
Thank you. Just one little comment. This may be self-evident, but just to add there, in terms of the role of a biopsy before surgery, I completely agree with all the statements regarding avoiding a biopsy for an encapsulated tumor. I guess the only situation where a potentially resectable tumor, where you're fairly certain, would be operable, where you would do a biopsy, is if you're thinking induction chemotherapy. Because before you subject someone to potential toxicities from chemo, if you think there's a role for that as preoperative therapy, you want to confirm the diagnosis before going ahead with that. So that's one small caveat, but otherwise, if it's an encapsulated resectable tumor, I completely agree. You can probably go ahead with surgery.
Thank you. And next question. I had a 7.2 centimeter type AB thymoma removed 3 years ago, followed by 27 irradiation treatments to my chest. Surgeon states tumor was slightly stuck to pericardium like Velcro. About 2 weeks into the radiation treatment, I developed tachycardia with minimal exertion, like standing while making a sandwich. PE was ruled out, and rate is now controlled with metoprolol. Recent echo shows new impaired early left ventricle relaxation. EKG shows new right bundle branch block. What cardiac issues occur with thymoma chest radiation? Conrad, please.
Yes, so radiation damage to normal tissues is dependent on the dose of radiation that we give, as well as the volume of normal tissue treated. When we plan radiation, we take the tumor volume or the target volume into account. That is what we're trying to treat. But then we also look at what we call the organs at risk. And those are the normal tissues that surround the target that we wish to treat. The thymoma sits in the anterior mediastinum, the front part of the chest, just behind the sternum. And to get adequate dose to the tumor bed or the area that we want to treat, we will include some lung volume and potentially some heart. It depends how big the tumor is, how far down along the heart it extends. The damage that we see occurs typically later after the treatment. We can get some inflammation of the lining of the lung or the lining of the heart when we're doing the radiation. Usually occurs towards the end of radiation because it's dose dependent. 2 weeks is very early to start seeing any of these effects, and they usually would present with pain or discomfort. The later damage is due to scarring of the lung or potentially causing some vascular damage to the heart. The doses that we use for thymoma are typically not high enough to cause muscle damage to the heart. That's a fairly roundabout answer to the question, but the reality is that we are very careful about what sort of damage we can do, and these should be discussed with the patient up front. We used to believe that the heart damage occurred much later, 5 to 10 years after treatment. We are now more aware that we would see differences at 2 to 3 years, and there we can sometimes see some reduction in function of muscle, but again, it's dependent on the dose and volume of heart muscle that we treat.
Thank you. And next actually group of questions. Are there any new emerging treatments, especially for stage 4 cancer? If tumors have extended to cover most of the liver, what treatments are there? Diets? If the spleen is affected by tumors, does it follow that the pancreas is in quick succession? Is a prognosis of months of life to live absolute if the abdomen is swollen with aggressive liver tumors? Arun, please.
Sure. So I'm happy to take these questions. So first, are there new treatments, emerging treatments for stage 4 cancer? I'm assuming it refers to both thymoma and thymic carcinoma. And the answer is yes. There are clinical trials that are evaluating various modalities of treatment. So as far as systemic therapy goes, obviously a lot of focus in recent years has been on immunotherapy, but we also know that there are new targets being identified and biological treatments being developed against some of these targets. There are combinatorial treatments, which could be immunotherapy in combination with chemotherapy or immunotherapy in combination with another form of immunotherapy. We just talked about the ongoing study of some time ago of ramucirumab, anti-angiogenesis along with chemotherapy. There are attempts to, as I mentioned, identify new targets and develop newer treatments. So a couple of weeks ago, there was a webinar as part of this series that focused on ongoing trials. And for those of you who attended it, there was a mention of some of these type of studies and drugs. An example is a drug called PT112, which induces what's known as immunogenic cell death, which is being evaluated in a phase 2 trial. And then in the future, there's a lot of hope that, what are called cell therapies, maybe some forms of personalized immunotherapy might emerge as potential options, which will be evaluated in trials. These are already being evaluated for other cancer types, and there has been success in certain situations, especially with hematological tumors. So there's a lot of hope in terms of these emerging treatments, some of them, or hopefully many of them, translating into actual clinical practice. These emerging treatments are not just systemic therapies like the ones we discussed, but there are other techniques which are evolving as well. So an example is improvements or advances in radiation therapy, which Dr. Falkson can speak about. I know 2 weeks ago, Dr. Anne-Marie Shepard, one of our colleagues from Memorial Sloan Kettering, shared details about an ongoing radiation study called the IMPRINT trial, where the idea is to develop techniques to treat, basically half the chest. So the point being, there are advances, several advances in fields beyond systemic therapy. And maybe, Conrad, you can just add to that if you don't mind, and before I answer the other questions.
Yes, I mean, one of the challenges that we've always had in radiation is what can we treat, what should we treat, and what can we treat safely? And so the main focus in radiation at this stage is to try and avoid normal tissue where we can and not cause toxicity with it, while covering the areas that are at risk for example, pleural metastases. And with the modern techniques in radiation, we're able to treat larger volumes of target area, but avoiding dose to normal tissues, almost like paint by numbers.
Thank you. So that's in regard to emerging treatments. In in terms of question number 2, and we again come back to liver-directed, liver predominant disease. So as we mentioned earlier, I think the focus really should be to identify good systemic therapies that are effective against liver metastasis. And I don't mean to overstate the case, but in terms of liver-directed therapies, so it's important to realize that will not be an option, unfortunately, for the majority of folks. But there may be a small subset of carefully selected situations where it may have a role, and that is dependent on a crucial, important multidisciplinary discussion. But systemic therapies are the goal to treat liver predominant disease, as it would be for advanced disease elsewhere. In terms of diet, that's a really interesting question. The short answer is there is no prospective data that I know of which speak to the consistent benefit from any particular type of diet in the treatment of liver-specific thymic carcinoma or any thymic tumor for that matter. There is emerging evidence to suggest, to demonstrate that there are metabolic effects of fasting or certain diets, but there's a lot to uncover there, and we wouldn't recommend going on a specific diet for liver-predominant thymic tumors. Question 3, is the spleen affected by tumors? Does the pancreas follow? The short answer, the answer is no, it does not. Splenic metastasis can occur. In some series that have been published of extrathoracic metastasis from thymic tumors, the incidence is about 3 to 4%. So it's actually quite rare. And there are certain instances where there may be tumor along the abdominal wall or in the sort of the pleural cavity, which may extend into the spleen rather than the spleen being involved primarily. But be that as it may, it's a rare situation. And there is no relationship between splenic metastasis and the pancreas being involved. On the contrary, I've seen cases of pancreatic involvement, which are the sole site of involvement below the diaphragm. So there's no splenic involvement, no liver involvement. So essentially, there's no correlation between the two that I know of. The 4th question is a little difficult to answer. It depends on specific circumstances for an individual patient. So it's difficult to say, is there an absolute, is there absolute information regarding prognosis of days or weeks or months if there is abdominal swelling? But I think it would be fair to say that if there is abdominal swelling, it is concerning. I would be concerned if I had a patient who had abdominal involvement and then swelling in the abdomen. And the reason for that is, it may not just be due to the tumor. It may also be an effect of the, liver dysfunction, which may lead to fluid buildup and other physiological changes rather than a bunch of tumor in the abdomen. And it is, sometimes a difficult situation because that liver dysfunction may prevent you from using treatments you otherwise would have. And that might make that may cause limitations in the type of treatments you can use. So nothing is absolute. There are instances where abdominal tumors respond greatly to systemic therapies, and that could be beneficial. So that's a difficult one to answer, but it certainly is a situation that demands attention and aggressive management.
Thank you. And next question. I was only diagnosed with terminal thymic carcinoma in December 2022, after 6 months of being told I had long COVID. I was to have 6 sessions of palliative chemo, but this was stopped after 4 sessions, as my consultant said the results were not good enough. I have now just started immunotherapy every 2 weeks. I am told that my cancer is rare. I would like to know how our consultants can tell that it is not viable to operate when so much is still to be learned of this horrible rare cancer. Who would like to answer? Professor Raemdonck, maybe?
Yeah, I can start off, but this is indeed a multidisciplinary question that should be answered together with our medical oncologist and radiation oncologist. It seems like this cancer did not look operable or resectable from the beginning. And then after chemotherapy, probably the tumor activity came down. maybe not the tumor size or the tumor volume, but the tumor activity. And I think this can be followed, certainly if it's a thymic carcinoma, with a PET-CT scan. If the tumor size is still the same, but the activity is no longer there, then it's still not a case to be resected, in my opinion, but just to be followed. I'm curious to see what Dr. Falkson and Dr. Rajan are saying on this.
Well, I would need more information, because does the patient have metastatic disease? Because if there is metastatic disease, it changes the picture very significantly. And there is no benefit to so-called debulking surgery. If there is metastatic disease to liver and other organs, then radiation can be of localized value, but not in terms of treating the disease as a whole. If it's localized disease, one could look at a combination of radiation added to the chemotherapies, but I think one has to have a structured plan, and again, a multidisciplinary approach, as you've mentioned. Dr. Rajan, do you have anything?
I completely agree. I think one would need more information. If the extent of involvement is not amenable to local therapies, whether that's surgery or radiation, once again, the onus is on us as medical oncologists to provide effective systemic therapy. In terms of the systemic component of management, we do generally start with chemotherapy. We plan between 4 and 6 cycles of treatment. Reasons to stop at 4 sessions might be either because after the 4 cycles, based on interim scans, there wasn't much benefit in terms of shrinkage or improvement of disease burden, or it could be a combination of that, along with the fact that an individual might be finding it difficult to tolerate treatment with several side effects and so forth. So it's a clinical situation where you need to use your clinical judgment and say, are the benefits outweighing the risks, or is it vice versa? And if it is vice versa, then you need to look at other forms of treatment. Immunotherapy is one of them. There are several other treatments for unresectable thymic carcinoma. And a special note of caution that I always share in discussions such as these regarding immunotherapy is that one should be cognizant of the fact that immunotherapy is not without risks in patients with thymic carcinoma, because almost 1 in 5 patients can experience significant side effects due to immune activation. So one needs to just keep that in mind. But as we discussed, more information would be needed in this specific instance to determine if the bulk of treatment going forward would be systemic.
Thank you. And next question, is proton beam therapy a good option for treating unresectable tumors? Professor Falkson, please.
Thank you. This is a great question, because proton beam therapy is the flavor of the month. I wanted to take a little step back and explain what ionizing radiation is and how it works to be able to answer this. Ionizing radiation is energy that we put into the patients. We target the cell, typically the nucleus, where we break up the genetic material. We have waves that can do this. We call them photons or gamma rays or X-rays. But there are also nuclear particles. When an atom breaks up, it consists of electrons, neutrons, and protons, and we can use these different particles to deliver the energy that we want to the patient. The technology for being able to deliver them has developed rapidly. Proton therapy is not a new therapy. It's been around for probably close to 50 years, but it was very impractical to do. The first unit was in Loma Linda, where they had a waveguide to collect these protons for treatment that was a mile long, so you can see that that was obviously not terribly practical. Protons don't have a different biological effect from X-ray treatments or even from electron treatments, but they do have a different physical property. Protons are used in treatments where we want to deliver dose to a very narrow distance of tissue. They can be manipulated so that the energy is given off at a specific distance within the tissue and don't penetrate. Historically, a lot of work was done to increase penetration of tissue, of radiation into the tissues. The old X-ray treatments used to burn the skin because we couldn't go through the skin without giving the maximum dose. Now the higher energy photon treatments we have allow us to give treatments deeper in the body. The modern technology, however, computer technology, allow us to do techniques with standard photons that can actually give us very tight conformal volumes of treatment. As I mentioned earlier, paint by numbers. The study that is ongoing at the moment at the Sloan Kettering is in fact a study looking at using one of these techniques called IMRT to treat larger volumes within the chest, but avoiding lung and heart. And so proton beam therapy is another tool for delivering accurate treatments. But it is not, the proton beam itself does not have better tumor properties than the photon beams. It's just the ability to try and avoid normal tissues. And in thymic tumors, specifically here, the heart is an organ that can be avoided, but it's not a magic tool. It's not a magic wand. There's always movement of the heart and one needs to put a margin around it. So even with proton therapy, we're not completely avoiding heart toxicity, but it may reduce toxicity in a small number of patients. Sorry for the long-winded answer there.
No, that was perfect. Thank you. Thank you so much. Okay. And the next question, I was diagnosed 5 years ago with a thymoma that was successfully removed. It was decided that no adjuvant therapy was needed. However, I am not the wiser if it is a cancer of the immune system or endocrine. Are there genetic links? Is there any gene therapy being tried on patients with thymic cancers? Because my siblings and my dad also had cancer of the immune system. So maybe I could start very shortly. That's a very interesting question because thymus actually is, of course, it belongs to immune system. It's an organ of immune system. However, it can be also regarded as an organ of endocrine with endocrine activity. However, when we think about thymus, we think about lymphatic or immune system. Thymus contains a lot of many different cells. When we look under microscope on the thymus, we usually see only or mostly lymphocytes, but there is a lot of other cells, including epithelial cells. And all cells of the thymus can transform into malignant neoplasms. If, for instance, lymphocyte transform into malignancy, it is lymphoma. And we are not talking today about these tumors. We are talking about malignant neoplasm derived from epithelial cells of the thymus. So this is the same organ, but different cells. Of course, these epithelial cells are very important for the thymus because thanks to them, lymphocytes can develop and mature properly. If there is any problem with epithelial cells, lymphocytes that are normally in the thymus can't develop correctly. But of course, thymus also produces some hormones. These hormones are usually associated with correct maturation and development of immune cells. So we can think about thymus as an endocrine organ, but it is usually, when we think about the thymus, we usually think about a very important part of immune system. Are there any genetic links? Of course, but and some of them are now discovered. For instance, in many thymomas, especially in certain subtypes of thymomas, there is such a mutation, GTF2I mutation, discovered. Currently, we know about it. There is such a mutation. However, its importance, for instance, for diagnosis, is very limited because it's not in many laboratories, in many pathology departments, this test is not available. But the truth is that for diagnosis, it is not needed in routine diagnostics to perform this test. And of course, there are also genetic abnormalities found in these tumors, especially in thymic carcinomas, that can be potentially a target for the therapy. And now I would like Arun to ask you to continue, and I'm sure you are the best person to talk about it.
Thank you, Margaret. So I actually almost word for word completely agree with what you mentioned in terms of the sort of categorizing this tumor. Yes, it is an immune organ, but as you mentioned, when we typically talk about a non-lymphoma, a thymic epithelial tumor, it basically comes from epithelial cells. So we don't typically regard that as an immune system, a cancer of the immune system. And the similar situation for whether this is an endocrine tumor. So yes, there are endocrine properties, as you so nicely described, of this gland, but it's not. When I think of it, I don't think of it as an endocrine cancer, as let's say thyroid cancer. And the analogous situation, for example, is the kidneys produce hormones as well, erythropoietin, and a kidney cancer is not considered an endocrine cancer. It's a solid tumor, as is in many ways a thymic epithelial tumor. In terms of genetic links, the only thing I would add is I'm not sure if the question is alluding to the ability of these tumors to be inherited and sort of genetic in that sense. So that's an area of active investigation. And to my knowledge, the one situation where there is a sort of hereditary component to it is in a syndrome known as MEN1, MEN1 syndrome, where thymic carcinoids can develop. And there are other tumor types associated with it, and that's sort of a hereditary condition. But now, and Margaret, you can speak to this, as there are much more refined ways of looking at genomic mutations in these tumors with these next generation sequencing panels, you pick up a lot of mutations, and a lot of them are what are labeled as variants of unknown significance. And some of these happen or are detected at frequencies which are high enough to suggest that they may be an inherited link, but whether that translates into a clinical scenario where it's a hereditary cancer is uncertain. And most of the time, you do not get that family history of multiple people having thymic tumors. On occasion, we have seen that situation, but in general, so far, based on all we know, it is not considered genetic in the sense that it's a hereditary tumor or a tumor with a predilection for inheritance for most individuals.
Yeah, thank
now,
you.
In terms of gene therapy, there is none that I know of that is being evaluated, but I'm sure that's an area one would focus on moving forward.
Okay, thank you so much. Yeah, of course, I agree with you. I should highlight it that, of course, thymic epithelial tumors are not as the tumors. Thymus is an immune organ, but thymic epithelial tumors are not tumors of immune system. Absolutely agree. I can only add from our experience. I know at least about one such family, father and son, developed thymoma. And what was interesting, under microscope, both thymomas looked the same. Both patients had myasthenia gravis. However, when the tumors were analyzed genetically, they didn't have the same genetic abnormalities. Both tumors differed from genetic point of view.
So the question there is, if I may add, is is there some environmental link, some viral exposure, something like that? Some of those things have been looked at, but I don't think anything has consistently panned out, you know, so it may be beyond genetics, if you agree. Yeah.
Absolutely, absolutely, yes. Thank you. Let's try to have next question. I had a thymic carcinoma successfully removed by surgery. This included removing 2-drop metastasis in the pleura, no metastasis elsewhere. I'm choosing not to have chemo or radiation, but to deal reactively. Typically or atypically, how and where does thymic carcinoma recur, and at what speed might this happen? Then, given that speed and an intention to be reactive, how frequently should I have a CT or PET-CT scan? Next, what do people who have or had thymic carcinoma actually die from? And the last sub-question, can a ketogenic diet halt the recurrence or progression of a thymic carcinoma? So I think oncologists should answer this question.
Sure. So maybe I can start. So in terms of the pattern of relapse, I think for both thymic carcinomas and thymomas, the majority of times the relapse happens within the chest. So these are intrathoracic relapses. And inside of the chest, the area that is most frequently involved is the pleura. So pleural relapse or recurrence. And the pericardium can be involved as well. And in cases of thymic carcinoma, there could be lung involvement, so lung parenchymal involvement, not just the margins, the pleura. So that is the predominant pattern of relapse, including in patients with thymic carcinoma as well. Now, since these are more aggressive tumors, yes, all of these tumors have the capacity to go outside of the chest, and more so with thymic carcinomas. Outside of the chest, the organs that tend to be affected more often are the liver, lymph nodes, which obviously can be involved below the diaphragm as well. And in some cases, other organs such as the bone, you know, the spleen we talked about, the brain, and so forth. The incidence of involvement of distant organs, especially the bone, you know, there have been large series that have reported on this, including papers put out by ITMIG. And the incidence is less than 5%. So this is relatively less common. And so is it for, I spoke about the spleen, it's about 4% based on certain series and so forth. So that's in terms of the pattern of relapse. It's predominantly in the chest, even for thymic carcinomas, for statistically speaking. At what speed might this happen? So that's very, very variable. It depends on tumor characteristics as well as patient characteristics that we may not completely understand. But the observation is that it could happen fairly soon after surgery, for example, or it can happen, you can see a relapse radiologically, but it may not progress even in certain cases of thymic carcinoma for several months or in some cases years. So I've seen that entire breadth of relapse and the rate of relapse. But at the beginning, since we don't know it, if we see that, for example, there is some liver involvement or a lymph node is involved, we do have some guidelines in terms of how often you repeat scans and how closely you should monitor it. And as we said at the beginning of this webinar, that's really based on clinical judgment. There are recommendations, but you have to tailor it to the individual patient. In terms of the frequent, I think question 2 is in terms of the frequency of scans. I think, as I just commented, it depends on the individual circumstances. What ultimately becomes an issue that leads to mortality from thymic carcinoma. So unfortunately, in many of these instances, it is organ dysfunction. So for example, if there is a certain organ that's involved, liver, let's say, and there's liver dysfunction, or it could be because, there's tumor near the heart and the blood vessels, and it compromises circulation, or lung involvement, with an effect on respiration. So again, it depends on the location of the tumor, on the type of treatment, on the potential side effects that have arisen due to it, and just general effects of the thymic tumor itself, such as things, effects on appetite and weight and so forth. So really, it's very variable. There's no right answer for this. And finally, the question about ketogenic diet, that is an absolutely tantalizing question. And, it's an area of research. As I mentioned, I think a few minutes ago, to my knowledge, there is no objective, consistent evidence that a certain diet, including a ketogenic diet, is therapeutic in a sense by itself. But there are data, that are emerging, especially in the last a few years, which show that there are metabolic effects of certain diets, not just a ketogenic diet, but even fasting, intermittent fasting. And, there's something actually called a fasting mimicking diet, which is not nearly as difficult to do, but it has the same metabolic effects, which some of which may be anti-tumor effects. There are also effects of dietary modifications on the immune system. There is emerging evidence that immune cells can be affected. The good ones can increase in numbers and the bad ones can decrease in numbers. These are all very early. So, we can't base treatment or say go on a certain diet based on these findings. There was one case that I'm aware of from New Zealand that was reported in the last year or two, where an individual went on with thymoma, stage 4 thymoma, went on a very significant sort of fasting diet and then, interspersed with a liquid diet. So it was pretty rigorous. And although I don't know the case particularly, I just have read the paper. And basically they talk about the fact that this patient had myasthenia, and the myasthenia actually got exacerbated. So in other words, these diets are not without risks. That was treated with steroids, and then there was tumor reduction. But whether that happened due to steroids or the diet itself, it's impossible to tell. So the bottom line is, it is not. This is an area of research. I do not personally recommend, a certain diet to be followed because there are a lot of things we don't understand, including the effects of the microbiome, and things like that. It is important to maintain a caloric intake when you're getting a lot of these treatments, because it can otherwise potentiate toxicity, and that can set you back. So I don't think I would say that there is objective evidence to say, in response to this question, that a ketogenic diet would halt the recurrence or progression of thymic carcinoma. And I would not recommend going on a specific diet, especially if one is getting active therapy, so that you can sustain the treatment and you're not prone to more side effects. That would be my take on it based on the knowledge we have today.
Thank you. Conrad, would you like? Yes, please.
I'm going to take the questions in the reverse order. I'm going to start with the ketogenic diet because the simplistic explanation why people say the ketogenic diet should work is because you're starving the body of glucose. This is a fallacy. Our brains are dependent on glucose. We make our own glucose for the organs that need glucose. So you're not starving the cancer, is the simple answer. There is a difference between a ketogenic diet and what we typically do, particularly in North America, is have a diet that is high, excessively high in carbohydrates. So reducing carbohydrate intake has been and is being shown in some other cancers, colon cancer potentially, to be of benefit, but not a ketogenic diet. And the ketogenic diet is potentially very, very dangerous in terms of organ damage, particularly with the hypoglycemia and the ketogenic phase of it. So I would not recommend a ketogenic diet for anybody without strict supervision, medical supervision, that is. Question 3, what do people who have a thymic carcinoma actually die from? This has always been a fascinating question in terms of what do patients with cancer die of? Because there's not necessarily a single incident or event that causes the death. It's not like a heart attack or a stroke, although these things can occur. But ultimately, the body is more complex than a motor car where the parts fail. It's a complex organization of all the organs working together. And as the heart and the lungs fail, so the kidneys and the liver also fail. So ultimately, it's the tumor burden that overwhelms the body as a whole, is the simplest way to put it, rather than a single fatal or terminal event. Then getting back to the patterns of spread for thymic tumors, in this specific setting where there already have been 2 drop metastases, I would think that pleural drop metastases are likely to be the highest risk at this stage. Certainly the tumor could spread anywhere else. I Would like to ask Dr. Marom regarding the use of PET scan, because I wouldn't use a PET scan. I don't think a PET scan is going to be more sensitive than CT imaging here. But there are some challenges to diagnosing pleural metastases. Edith, would you?
Yes, again, as I said, PET CT scans are advantageous for specific people. And that is if the tumor is very aggressive, because then we may notice metastatic disease earlier when it's tiny and we cannot see it well. Sorry. But in general, it's not routinely used.
If I may just add to what Conrad mentioned, and I neglected to mention it initially, in terms of this ketogenic diet, or any diet for that matter, I think one thing I just want to reiterate also that Conrad mentioned is not only is it a fallacy to think that, just starving yourself of glucose would help, because the body makes glucose, frankly. It's called gluconeogenesis. But beyond that, there are other substitutes in certain diets. So let's say a high fat content and even metabolic changes due to just starvation as such, which can actually damage other organs. It can affect the heart, it can affect the kidneys. It is not free of risk. So I think as a group, we would implore people to be very, very careful about this. It's a topic for discussion, but it's not something that should be taken lightly. And it's not as simplistic as saying, I won't take glucose, so the tumor, will not grow, because that's not how things work, basically.
I just wanted to add one more thing before I started coughing. A scenario with thymocarcinoma. This is a scenario where sometimes we do ask for a PET CT. As I said before, with the very aggressive tumors, the PET CT sometimes does show uptake and showing us areas that we may have missed otherwise for distant metastatic disease. So in a certain scenario, when there's a big tumor and it's thymocarcinoma, and we're thinking of doing a very aggressive therapy, major surgery, you really don't want to go into that, which is complicated to get over with, or let's say a lot of radiation, things that may cause local damage that one has to recover from. You really want to go for this strategy with very aggressive therapy. If you're aiming for a cure, you're aiming to eradicate all the disease. So before you go into that with a very aggressive local tumor, you really want to make sure that there's no disease elsewhere where you're not operating or not giving radiation. In that scenario, with an aggressive disease that we know does take a lot of glucose up with PET CT, that's a scenario where sometimes we will specifically ask for a PET CT before we embark on such a major surgery or major radiation, because it may add value by highlighting metastatic disease, which we may have missed before. So as you can see, we tend to choose to use PET CT in intersection parts when we're changing, where it will change our clinical management tremendously, and we have the right disease to do it, but not routinely on a monthly or a yearly or half-yearly basis.
And the other point that I just wanted to make, and Dr. van Raemdonck did mention it earlier, I would not do any imaging within the first 3 months. I'd wait for the surgical response and reaction to settle, because you just mislead yourself because you see inflammatory changes early on. Somewhere between 3 and 6 months is when I would do the first scan.
Okay, thank you. I'm afraid we have to finish at this question at this moment. Fortunately, majority of the questions could be answered. Unfortunately, we didn't have time to answer the questions in the chat. Thank you for all submitted questions. Thank you for participation. And I wanted to thank you to the physicians, to doctors who agreed to spend their time here and answer these questions during this webinar. Thank you so much. And I wish you all a good day. Thank you. Thank you. Bye.
Thanks.